Good afternoon, everyone. My name's Christina McHale, and thank you for participating in today's 922nd Justice Clearinghouse webinar. During today's webinar, Danielle Mullins and Gary Steiner are here to talk about addressing consent decree challenges with electronic health records and analytics. During today's webinar, we'll discuss concepts for using modern technology within custody environments to address unique challenges presented by consent decrees and court mandates. This information is relevant to all types of custody arrangements. You'll learn different ways of using technology to identify root causes, monitor and demonstrate measurable progress, and reduce the overall impact of the decree and mandate. In addition, we'll discuss methods of proactively identifying hotspots before they mushroom into crisis, litigation, or simply subpar outcomes. And finally, we'll discuss information-based resource allocation as a preventative measure that allows or that also increases in clinical outcomes. Our speakers today are Danielle Mullins and Gary Steiner. Danielle Mullins currently serves as branch chief for Health IT and Informatics for the South Carolina Department of Corrections. He oversees the departments responsible for supporting, enhancing, and managing the medical technology platforms and software solutions that allow the agency to deliver care to 31 different correctional medical practices across the state. Gary Steiner currently serves as the Chief Technology Officer for Medicalistics. He has more than 27 years of experience in the healthcare field, serving as Director, Vice President, CIO, and now CTO at national healthcare technology companies. And I also do want to take a moment to thank our friends and partners for helping with today's webinar. Today's webinar is done in partnership with the National Sheriff's Association and Medicalistics. We truly appreciate working with organizations like the NSA and Medicalistics who are so committed to enhancing and growing the profession. And now briefly before we begin, I'd like to share with you some information about the Justice Clearinghouse. The Justice Clearinghouse is the only peer-to-peer educational program for justice professionals that emphasizes the multidisciplinary nature of an effective justice system. Through our year-round virtual conference, our audience and subscribers begin to develop a comprehensive understanding of the justice system while breaking down its many misconceptions. While our events are free to attend live, our subscribers receive 24/7 access to over 900 recorded webinars and are eligible to receive certificates of attendance that can be used when seeking continuing education credits. So if you're not presently a subscriber, I would invite you to join today and support our work. And the last thing I want to address with everybody are some basic housekeeping items. First, this event is being recorded and the formal presentation is scheduled to last about 60 minutes and will be available to subscribers on the Justice Clearinghouse website. Second, this is a listen-only event, but you can type as many questions as you have in the GoToWebinar toolbar. We'll take as many of your questions as possible at the end of the webinar. Next, if you do experience audio issues during your webinar today, such as the audio cutting in and out intermittently, consider dialing in using the phone number that was included in your email invite. After you dial in, when the system asks you for a PIN, you can simply bypass that by hitting the pound key. And also, folks, we do have a handout as part of today's webinar that takes you to a link so that you can download a special white paper from Medicalistics. So don't forget to download that from the GoToWebinar toolbar. And as always, we love learning about our Justice Clearinghouse community. So today's question, I'd like to learn how many people are in your different agencies or organizations? So again, how many people work for your agency or organization? Your options are 1 to 50 employees, 51 to 100 employees, 101 to 250 employees, 251 to 500, or more than 500 employees. We'll give everybody just another second or two to get your votes in. We really appreciate you all doing this. It really helps us understand more about you and the complexities that you're facing. And it's just really helpful. Thank you so much for doing it. Outstanding. Well, it looks like we're just about at a quorum. I'm going to give everybody another second or two to get your final votes in. Let's go ahead and close the polling and share the results. Interesting. 16% of you're working for smaller agencies, 1 to 50. Nobody is in an agency size of 51 to 100. 13% of you said 101 to 250, and 23% of you said 250 to 100 to 500, and 48% of you said more than 500. Thank you all so much. I really appreciate it. And finally, after today's webinar, there will be a follow-up survey, and we do ask that you complete it. Your feedback helps us shape everything we do here at Justice Clearinghouse. And so with that, let's turn our presentation over to our instructors for the day. Welcome, Gary and Daniel. Daniel, it's all yours.
Thank you. Good afternoon, everyone. Appreciate you all joining us for this afternoon. My goal for you all today is at the end of this webinar to feel comfortable with exploring some options you have within technology to manage the demands and challenges of a correctional environment, and also the data reporting that comes with those court mandates or consent decrees. And what this really condenses down to is how can you better pursue excellence in what you're doing, the teams you're working with, the ones you're leading, and the organizations you oversee. And so to kind of walk through this, I use analogies to help explain things from time to time. And this concept, I think, is really well illustrated through a simple analogy. This is kind of like a climb. Imagine, if you will, you're pushing this giant boulder up a hill. And at the very beginning, every step is extremely challenging. Every inch of progress you make is so hard to move. As gravity is pulling everything back down on you, the weight of the boulder is pushing back against you, your shoulders and arms begin to scream every step you take. You're pouring sweat with every movement you make. And sometimes you may even feel like you're not moving at all. And even more so, you can't see when the hill stops or what's coming next beyond it, because the boulder blocks your vision. So all you know is that you're just pushing and pushing and pushing. And at a certain point, you hit this top, you hit the crest, and all of a sudden, gravity's not working against you anymore. The weight of that boulder is now almost neutral. It almost rolls itself forward. And you can start seeing the progress. Every step you take, making an impact, the difference in how far you've come. You can look back and see the bottom of the hill and see where you're at now in the climb, and you start picking up momentum. And oftentimes, this is where people stop, unfortunately. This is where we get hung up. We get caught in this cruise control or coasting mindset. But what analytics can do is take that mindset and shift it. And that's what we want to explore today, this mindset shift that can come from digging into things like this and completely transform everything around you in the workplace to where you don't just hit this plateau, but instead you're able to continue on. Because eventually what happens, and I've seen this myself, is that plateau ends. And so the boulder starts going down the hill, and now it's moving faster and faster and faster. You can't even hardly keep up with it. And if we just keep pushing forward past that initial glimpse of progress, that initial impact, as soon as we hit that next climb, you don't have to push as hard to get movement. You have all of that momentum, all of that inert force carrying you forward up the next hill. And so everything you've done over the first hill, that second hill, although it may be bigger, is a little easier. And the third hill and the fourth hill and the ones you come up to as you continue forward, you use that momentum, you use that change, you use that driving force to maintain that velocity, to maintain that progress. And so this first slide gets us started on those first couple of steps of the climb. That's really figuring out what those root cause issues are and how to do a root cause analysis. Because at the end of the day, we have to figure out what the root issue is to the problem we're facing. And oftentimes what happens in medicine or systems operations is we have a number of issues that may pop up on a day-to-day basis. So for example, you go to the doctor because you have a cough or some indigestion, and the doctor's faced with the decision how to treat that issue. They may give you something to stop the cough so you can sleep at night. They may give you something to help with the indigestion so you can be on your way. But did that really fix the issue, or did that mask it and make it somewhat manageable? Well, for an operational example, let's say I have 200 inmates coming from a county facility to my intake facility today, but I only have 6 officers and 2 nurses that showed up for work today. And now I've got to figure out how in the world I'm going to get all these people processed in effectively. And so as the manager of that team, you would divide up the steps and just knock it out. You can get them all done, maybe even in record time without a single hiccup in a perfect day. But that same scenario is going to repeat itself potentially next week on Wednesday when nobody shows up to work again. And so because we can get easily caught up in just making things manageable, we can let these systemic problems sit unnoticed underneath everything until one day we experience a system failure or a very unfortunate event. And then boom, we're at this point where we get caught up in litigation, or we're stuck in court, you're faced with sanctions, system changes you can't figure out how to pull off, and now you've got a consent decree or court mandate to comply with, and none of the resources in your pool to be able to do that. And it's at this point, going back to that boulder analogy, where people get lost in the climb, people get lost in that push, they start sliding sideways because of the weight that's pushing back on them instead of moving forward. The boulder defeats them, they just start going backwards, they quit, they leave, they give up. The demand for change or for information or for solutions becomes so overwhelming, they can't figure out how to do anything else other than just walk away. And that's where analytics and EMRs and data and information can be very transformative. And so to break this cycle, we have to take that first step extremely wisely and with a lot of caution, and spend all of our efforts on digging in and getting that firm foundation to push from. And that's where this root cause analysis comes in, helping to figure out what's the core issue here, how do I take care of that, and then move forward. So quickly identify root causes is a key process to mandating, or to managing a court mandate or court decree. So we want to use analytics to modify core process and to continue to resolve those system issues in a way that prevents them from hitting that critical mass like they did. And so often we hear this age-old cliche of work smarter, not harder. So much that's becoming what we're really trying to drive home with that root cause analysis. And our goal here is to start addressing the issues at their core to prevent daily symptom management from draining those resources. So if all I ever do is handle those symptoms, is manage that surface level information, then all I ever achieve is that short-term relief. And I never become successful. I never really succeed in getting out from underneath the decree and getting out from underneath the mandates. And so using a root cause analysis is very important in digging into the why, the how, so I can start identifying and controlling variables in the scenario or problem. And then once I'm able to identify them, develop some consistency that I can put together a functional corrective course of action.
So, Daniel, this is Gary. I have a question for you. This sounds nice, except my clinicians are generally overtaxed and overworked, and I'm underfunded. I'm curious why, given those circumstances, why do I care about finding a root cause versus, solving the problem today and moving forward?
So at a surface level, we need that short-term relief. And if all I ever do is just handle that short-term relief process, then I'm never able to effectively cause lasting change. I'm never able to get out from underneath that mandate. And so I'm constantly stuck in this hamster wheel, and I can't get off. I can only handle what's standing right in front of me. But if I start looking at the root cause of an issue, if I start digging in and figuring out what's going on and why, then I can start tackling at that core issue and causing a long-lasting and effective change to drive forward that progress. And I can do that using a number of different tools, which we'll unpackage here in a few minutes. But again, it goes back to that work smarter, not harder, because that's really what analytics and information allows us to do. Not so much that it's a cliche, but that it become a mindset and a way of management and a way of decision making.
All right, so I think I'm kind of sold on why I should do a root cause analysis. Can you tell me a little bit about how I would then go about doing that root cause analysis?
Absolutely. So there's a couple of core principles in a root cause analysis review that you want to highlight, that you want to focus on. And that really begins with correcting and remedying that root cause specifically, and not just handling that symptom. Again, not just taking something at the surface level, but digging in a couple of layers in to figure out what exactly caused it. And we also, while we're doing that, we don't want to ignore the importance of treating those symptoms for that short-term relief, because your frontline staff will especially appreciate you by handling that short-term relief. They need to see that day-to-day impact, that day-to-day progress, and feel that appreciation or feel that release of pressure a little bit. But from a systems perspective, if all we ever do is that, then I never address the core issue. I never again cause that significant change. And I have to realize at the same time that there may not be just one singular root cause. There may be multiple core issues that I'm dealing with that may overlap, that may be separate. And so I really need to dig in and tease out the details, focusing on how and why something happened, not necessarily so much who is responsible for that breakdown. Now, that who is important, don't get me wrong, accountability is really key when we're talking about driving forward change, and that's part of what the court mandate is creating an accountability component. And we'll talk a little bit more about accountability later in the presentation as well. But again, the important and critical piece here is to not lose sight of is that how and why. And in digging into that how and why, we want to make sure we're being methodical, finding that concrete cause and effect evidence to really back up that root cause claim. Because when we find one of these issues, we want to dig in deep onto it, resolve it at the core, and then watch the impact of that resolution grow through that solution itself. And in order to do that, we have to be able to provide enough information to have that corrective course of action. And eventually what we're able to do, once we get this concept and practice down, we're able to consider how that root cause can be prevented in the future or how it can be replicated in the future. So really the first goal is to discover that root cause, that core issue, that core event that occurred. And in this case, what's causing those system failures that result in the court mandate or consent decree. So at the surface, there may be some apparent issues. And maybe that's even some of the objectives within the mandate itself, but that may not be the core issue that derailed the system. And beyond that, the second goal is to understand how do I resolve or mitigate or compensate for any of those underlying issues within that deficit. And then finally, how do I learn from this analysis to systemically prevent those future issues and drive that development towards consistent success? So to perform one, the easiest way I found is just to ask a simple question: why? It's every 5-year-old, 4-year-old, 3-year-old favorite question to ask in the world, and oftentimes we can miss the importance of it as an adult, but it really has a profound impact when we're looking at problems in today's society or in operations or in system management. And so if we ask why, 3 or 4 or 5 times, typically we start running into a situation where we can no longer answer that question. So for example, let's say my system failed to meet certain standards, and then we're stuck in a court mandate where I have to make sure all of the offenders that hit my facility doors are classified within 30 days of arrival. And so, we failed to do that, and I want to start doing a root cause analysis to understand what happened. So the first time I asked myself, why did this happen? Well, we didn't meet this objective. It's our own policy. Why did that occur? Well, oftentimes in those service level conversations, the answer is going to be, well, we were working on it, but we just ran out of time. Okay. Well, why didn't we have time? And that's that second level why there. And the answer in that conversation, when doing some retrospective thinking or analysis, may be, well, we only have 4 people to work right now in classification, and the incoming caseload is massive compared to what we normally handle. And so we want to ask why again. Well, why couldn't we get it done with 4 people? And this is where we start getting some really useful information, is about typically that third or fourth why. And so during that conversation, you discover, well, the process takes about 30 minutes to complete the paperwork. And then they have to go enter that same paperwork and information into the EMR over here. And then they can move the offender over to the next step that takes another day to process. And then there's 2 other steps beyond that take additional time to process. And so, it might be very obvious, but the fourth why is, well, why does it take so long to process everything? Why can't we do this faster? And it's a simple answer there, but it's a profound one too. We have a paper process and electronic process in place, and we're duplicating, if not triplicating, some of the work. And entering this information isn't, just a wave of a magical wand or a snap of the fingers. It takes time. And so finally, the really impactful why is the final one here. Why are we duplicating the work on intake when we only have so many resources in such a tight time frame? And this is the question that becomes very difficult to answer. There's not a good answer for that. And if we don't ever realize that that's really what's going on behind the scenes, we just see, well, I just can't get this done. Maybe if I just hire 1 to 2 more people, that'll fix it. But as a correctional employee myself, I understand that most correctional entities are operating with a very limited budget. And we really have to maximize the use of our finances to the best of our ability. So is hiring that 1 to 2 extra people really the best use of my resources? Maybe, but not necessarily. If I dig in on that process itself, like we just did, we can realize we're duplicating and, like I said, even maybe triplicating the work by the standard way we're doing things. What if instead we filled out the form as we saw the patient or saw the offender? Well, that might help some, but let's take it a step further. What if we created the template within the electronic medical record that captured that information and then fed it into our classification system? So I can do data entry in real time at point of care or point of interview, and then maybe reduce that administrative tax or administrative time it takes to do that later in my day. And by doing so, I don't just get a little bit extra time back. I reduce my resource consumption. Maybe the paper forms I was using cost me an extra $1,000 a year, and I was, just burning those supplies pretty much. What if I could take that extra $1,000 plus the extra resource time I've gained now and reinvest that in the system where I can drive more progress? And that's really where this root cause analysis allows us to do, is dig into things at a very deep level and find those efficiencies and gain those efficiencies, realizing them, and then reinvest that in energy and that information back into the system itself. So the next core piece to this is looking at not just taking the information you're able to gain from it, but learning from it as you go through. And like I was explaining a minute ago, with that workflow analysis where I'm seeing, well, I'm starting to duplicate and triplicating work, I can start learning, well, maybe I have a lot more other inefficiencies built and baked into my system that I don't even realize, because it just naturally occurred over the last few years. We've just continued to add on step after step after step. And oftentimes the result of a mandate is a lot of process change and a lot of system review, and things can get very confusing, very, very messy, very difficult to track overall as a whole. And so we want to make sure as we're going through this root cause analysis, we're not just checking a box and saying, okay, figured out the issue, let's move on, but learn from that issue. How did this occur? What triggered it? What was the precursor before it? And how can I dig in to prevent that in the future? And part of the way we do that is by having a multidisciplinary approach, making sure that it's not just one perspective we're approaching a problem with. So in a correctional environment, there are a lot of different divisions and entities that have to collaborate and cooperate with a very close-knit strategic plan to handle some very difficult situations on an everyday basis. And without that multidisciplinary approach, custody staff, medical staff, behavioral health and mental health staff, things would fall apart very, very quickly. And so it's really important to make sure we have that multidisciplinary approach, to have that overlap, to have that additional perspective. And so what I found is that we have some great examples within the correctional environment to kind of look at, such as treatment teams.
So, Daniel, I know kind of how treatment teams work in a hospital. I think most people are probably familiar with that, but there's an awful lot of differences between a hospital and, a prison or a jail environment. Can you tell me a little bit about how treatment teams work in a corrections environment?
Sure. So again, fundamentals are still there. You do have that multidisciplinary approach where there are medical staff present, whether it's just nursing or maybe there's a medical provider present. There's of course behavioral health and mental health staff present. Maybe it's a social worker, the patient's counselor, a psychiatrist, psychologist, and of course in our correctional environment there's custody staff present as well, and administrative staff present to address any concerns. And you want to talk through the patient's issues, the patient's concerns, patient's needs, and make sure we're managing those. And so what often happens in a correctional environment is there's not a lot of resources to go around. So you're grasping at straws to make sure all of those different players in the room to start with. But if you remove an EMR and you remove analytics, what you're left with is just paper records. And so there's a lot of these handoffs that become extremely messy or confusing to ensure that they happen effectively. However, with an EMR, those meetings can be a lot smoother. So you have the ability to review that patient status, review those patient needs effectively and collaboratively, and really determine that multidisciplinary and therapeutic approach to make sure their needs are addressed. Because all the information's there, it's available on demand. I'm not, walking a paper chart from one medical office to somebody else's office and having them sit down, read through things, sign things, scan it in. and all of that. So it's a lot simpler and a lot more streamlined. And again, that's one of the things we're looking at here is how can I gain efficiency and get some of my resources back to be able to address the overall issues. So all of the information available in the EMR improves that collaboration. And with that collaboration, patient outcomes impacted. And because of that patient outcome impact, you're able to succeed a lot more and see improvement in compliance with those court mandates.
So if we were to expand perhaps on the treatment team concept in corrections, is there a way that telehealth can play a role in that?
Significantly. So, of course, with today's day and age, COVID has drastically impacted everyone's world in a number of different ways. And the medical world, and even more specifically the correctional health world, is no different. So with the significant increase of Zoom meetings and Teams meetings and any other virtual care platform, they've all significantly expanded over the last 12 to 18 months as a result of COVID directly. But even prior to that, telehealth plays a significant role in ensuring that adequate patient care is delivered. And when dealing with a lot of these court mandates, what often happened was we had a deficiency in care where there wasn't good communication, where there wasn't a good handoff between care components. And so what we need to do is make sure that handoff is firm, make sure that that information flows without any hindrances. And telehealth plays a significant role in doing that because it removes those physical barriers between people so that I don't necessarily have to have all of those resources in the room at the same time. I can have them in a virtual room, and I can actually increase the efficiency of the team by reducing the wait time, by reducing the resource allocation physically to an area. And one of the things I've seen that's significant in the last few years is a significant resource shortage in the psychiatry realm, where it is increasingly difficult to obtain psychiatry coverage at an effective and reasonable rate, especially for some of these more complex patients and larger populations. And so being able to have those resources right local to your facility may be very difficult, but in a virtual care delivery system, they can be anywhere. So I have an increased resource pool in which to tap out of. So absolutely, telehealth would be a significant boost to this process. And getting back to that process, we really want to make sure we're focusing on the progress this process is driving forward. So as we're looking at these issues that are core pieces to your consent decree or to a court mandate, we have to be able to not just say, hey, yes, we're making progress, but we have to be able to define it, to measure it. And so in the context of our conversation, that progress would be scoping out where we are when the consent decree is issued, because that's, looking at that time, what caused this to occur, going back to that root cause analysis and figure out where things broke down and why, and where all of the areas that are listed within the mandated changes are and what their affected areas and their terms of status they are. And then looking at, based on these mandated items and changes, where do we need to be? And then what does that trajectory look like? And I think, again, the key here is to create both a quantifiable change process to show that progress, but you also need that qualitative review process to verify that what you're doing is having the impact you want, that change is occurring, that the change is effective, that you're making that change and moving things in the right direction. Because what often can happen is that we get stuck drilling into details that might seem significant, but they may not be those core items. It may not be the driving item behind the issue. And that's where we see that root cause becomes very invaluable. And in a crisis, what I've seen is that leaders or change drivers, our natural tendencies can be geared towards taking more risks in those scenarios. We have a heightened sense of focus that shifts us away from those non-essential items. And eventually, without that foundational understanding of what's really driving some of the things we're doing and driving some of these core items in the court mandates, we might make changes and decisions we'd never originally make that might have unintended negative outcomes or never truly address the core issue. So what we end up doing is just burning even more resources into the ground without having a desired outcome. And so making these decisions on the actual decree items might produce some of that progress, but oftentimes what I've seen is that the driving issues behind these decree items may be very different. So an example above, we'll think back to the intake and my staffing issue. If I just hired 1 to 2 more people, that might be enough to change the outcome of that classification process. Maybe I'm able to hit that 120 a day target I set for my staff. And we could put that on a dashboard very easily. Anybody could put that in Excel, and we could show that we're hitting that consistently at a daily or weekly, a monthly pace. But the second I lose one of those resources, or let's say something happens with the intake flow, let's say it increases, I'm right back to that same core problem and all my progress is lost. And that's where understanding this driving force is really critical, so that I can make changes and decisions based on its measure instead of necessarily just the decree or consent item itself. So if something has to be added to that classification process, maybe I retool that entire workflow to accommodate that. Maybe I know what we can and we can't enter the system. Maybe I split things up between different resources. I identify a streamlined process to walk through with custody, the medical, and behavioral health clearance in a more efficient manner, because those are the driving pieces behind getting somebody processed in that first 30 days. Not just that I clear them, but I want to make sure we hit all of those different checkpoints. And so I need to track those 3 areas, and not just their general progress, but also track that reaction time and see that daily or weekly or monthly movement, so that I can get a tangible pulse on my overall system and identify any type of inefficiency or a bottleneck, and then figure out how to address them at that level. And that's where the data comes into play. The ability to review system progress and that change impact is the critical key here. So after I can start seeing some of that progress, I'm able to consistently and quickly make a world of difference in the outcome of compliance, because I'm able to start looking at some different perspectives. I'm able to start doing a little bit more reporting. And then there's 2 perspectives to look at inside reporting, and that's reactive informational analysis and proactive informational analysis. And so it becomes really easy to model historical data in the grand scheme of things and to figure out what went wrong. We can always look back and say, in a perpetual state of review, especially after a consent decree is issued or a court mandate's issued, because typically there's a major event or an issue or maybe a series of issues that caused it. So we can look back and say, well, these things occurred. We want to focus in on them. We want to figure out what happened. We want to figure out what broke down and why. And that's great. That's good. We want to make sure we do that. Again, going back to that root cause analysis. But it's also really important to make sure the information flow and the discovery process doesn't get caught up there. Because what can happen is 5, 10, 15, 20 years go by, and you might make some changes and some improvements, but things are still very much the same. However, if we take proactive analytics and plug into that same setup, that can change that whole outcome. They can start modeling future data, modeling future outcomes, and maybe identify some of those future areas that might have issues we aren't aware of yet, that may be sitting ahead of us in the path to success. And because what I realize is that I don't just need to know, going back to our scenario, what happened last month for the intakes. I need to be able to look at last month in comparison to multiple months and data sets, look at the benchmarks that we have on these processes, and then I can figure out what other opportunities are there for improvement, what other opportunities are there for change from this information. Because if all I ever do is just digest that data and never do anything with it, it's nothing more than numbers. But information can drastically transform our workflows. It can drastically transform our work environment by giving us the ability to have decision-making processes put into place. And this is where I can really start mapping out progress and start looking at future state movement on these driving issues behind those mandate items to make data-informed decisions.
So Daniel, I've got a couple questions for you. A moment ago, we talked about consent decree, measuring consent decree compliance and measuring the different items that drive consent decrees. In light of the 2 tools we're really discussing today, the electronic health record and the analytics package, can you tell me which tool do you use to do those things?
So really it's a tandem of both, because without the EMR, you're operating within an environment where it becomes very difficult to quantify or qualify any type of care delivered. So if everything's on paper or everything's in disparate systems or disparate databases, it's very difficult to make sense of it. And reporting compliance, reporting improvement, reporting progress becomes almost an impossible task. So an EMR plays 50% of the vital role here. And the other 50% becomes an analytics tool. So again, you need both to really drive the success at a rapid pace. And that analytics tool allows you to not just have information stored in an EMR somewhere, but also make sense of that information. Take that information, repackage it, and correlate it with different data sets, different data points, and start pulling information between multiple databases to start figuring out what's really going on behind the scenes at the very core values.
Okay, so, and my last question is on this screen anyway. You spoke about reactive graphs and proactive graphs, and it seems like maybe if I just started using my proactive graphs now and consistently use them going forward, that I may not need reactive graphs anymore since I'm proactively addressing everything. I just wanted to get a feel from you if that seems accurate or not.
Well, that can be an easy trap to fall into. I'll put it that way, because proactive graphs are really great for a specific purpose. They show us what I need to do. They show me what's sitting in front of me I still need to accomplish. What do I need to do in order to be compliant with that court mandate, with those objectives? But that's only half the climb here. I need that reactive data as well. I need those reactive graphs because they are that historical review. They show if I actually was successful in that compliance process. And so they have to work in tandem, just like that EMR analytics tool. These both help identify the changes that I've made and I'm continuing to make, and helping me evaluate were they effective, were they impactful, and I need to be able to do that at a glance, at a moment's notice, and maintain that pulse in the overall system. And so to successfully exit that mandate situation, you'll need to be able to seamlessly produce and utilize both models. So with that in mind, now that you're starting to, you're getting to a point where you can start getting some of the information, and I'm starting being able to make some of these decisions, I need to start looking forward and figuring out how I can drive that change effectively. And that's where we really start picking up the pace with that boulder analogy. I start hitting that plateau, that flattening area where I can start moving things a lot faster. And in doing so, I'm able to identify areas of concern or issues before they even occur. And that's what we're going to dig into next, is trying to find and proactively identify those hot spots before they hit that critical mass, before they hit that crisis level, or before another crisis event occurs. So looking at the data and information we have in our hands, oftentimes there can be a couple of areas that really stick out on that initial glance review. And you want to dig in on those areas. Again, going back through that root cause analysis, and you can take that cycle and repeat it over and over again in a couple of different areas and from a couple of different perspectives to really determine what's going on, what might be causing those issues, or frequent areas of concern or review. And we don't want to just stop and look at that singular information, but actually start looking at it as a trend over time. So now I need to figure out, is this a cyclic event or is this a one-time event? And if it's a one-time event, what caused it and why, of course. But if it's cyclic, what triggers it? What are the precursors? What key performance indicators, KPI, can I spot within this information that I'm transforming or viewing that either spikes or falls and correlates with that cycle kickoff? And that's where analytics becomes invaluable. It's where an EMR and the data it allows you to obtain becomes very invaluable. And from that, how do I effectively position resources? How do I strategically adjust workflows, or how do I maneuver personnel to prevent these issues from occurring again? And so when we start digging in on the information, we might see that, 1 month out of the year, I know it's a holiday season towards the end of the year. So counties are having to clear out their jails and send guys faster to the state system, which creates a larger influx of offenders for me at the state level, because they're dealing with their own influx. They're dealing with a ton of people coming off the streets, they're getting picked up. And, my policy says, it's 30 days from booking to classified and process. And of course, my court mandate didn't give me this nice little holiday pass. So I need to figure out, what am I going to do? And if I know this wave is coming ahead of time, and I have time to prepare myself for that, I have time to find resources to prepare my system for that, then I can address it. I know that I'm going to have an issue if I don't have enough resources, and that issue can create a major problem in classification and offender management, and of course, medical management as well. because I can say, hey, it's July or it's, October now. I may have a month or two to figure this out, and then we can make some adjustments and start, working on some solutions. Versus, hey, it's November 24th. We've got 7 days before we know the rush is here. I'm in trouble. And so if I see this as an annual cyclic issue, in our example here, I know that every year during that holiday season, I tend to have this sizable increase at a county level or a state level. And so I need to position my resources that I do have effectively to manage that. And in doing so, it's not just that I add or I make decisions to add resources, but I can start looking at some of the guidelines and standards that I need to adhere to that may help identify what needs to occur for these guys coming in to make sure I don't have a crisis level event that occurs and further sets me back in my court mandate compliance. And that's where we can start looking at guidelines, looking at NCACHC standards, ACA standards, and start laying out their metrics to help me figure out what data points are important or what goals do I need to set. And that'll help get our system of success developed and get out from underneath the consent decree. And we can take them and work backwards to start planning and identifying necessary resources to hit our goals. And see that, in our example, I need to make sure these guys are clear through intake and processing in 30 days or less. Or I need to be able to make sure that, if I have an offender that goes on crisis or suicide watch, I have an appropriate clinician resource available to address their crisis issue. And that I'm not stuck dealing with these issues as they occur, trying to find resources and manage the crisis at the same time. But with the information I'm gathering, I'm transferring or doing, I'm able to face these problems in advance, knowing that I'm going to run into these problems in the future. So I can start seeing where these hot spots are. I can start seeing these things before they occur by looking at the data sets and looking at the data models. And I know that if these things are out there, I need to make sure I have the resources to tackle it.
So, Daniel, I know you've been doing this for almost 10 years now, but if I'm new to this notion of looking for hotspots, are there areas in custody environments where hotspots are more likely to occur than others? In other words, are there maybe typical places that I should start looking in my jail or prison environment?
I would say so, most definitely. So just to list out a couple, I think probably the most frequent or most problematic areas are the ones that are high pace and have a lot of moving pieces. So quite often that'll be your intake areas. And that's why I use that as an example in our conversation so far. Because there's so many different components to processing somebody in. It's not just, they show up, you book them in, you give them a number and you put them away. That's not necessarily how that process works. There's a lot of different things that have to go on to make sure that everything is done appropriately, that staff safety is considered, offender safety is considered, the medical issues are addressed, mental health issues are addressed, and that things aren't, slowed up in that process. Because what happens if one thing's missed during that whole process or one thing's delayed, it can create a major bottleneck or a very large backlog in that offender management process. But it's not just there. There are some other settings that I would put on people's radar to consider as well. And that would be more of your higher level psychiatric or crisis settings. So if I have a higher acuity or a high acuity psych setting or a crisis management unit, that would certainly be something I'd want to look at and make sure we have a lot of focus on resources invested in and make sure we are very closely monitoring that cycle of patients in and out. But not just there as well, also emergency and medical care areas. If I have an infirmary or an emergency department in my system, any type of medical unit with a high volume or a critical event process that I have to make sure it hits on time and fires on time without hesitation or delay, I want to make sure I have that exact process in place, the specific responses to where if a crisis occurs or if a medical emergency occurs, there's no delay in care delivery. Now, I will say there's one that I've often seen that gets forgotten, or if it flies under the radar a lot of times, and that's actually the chronically ill population. So in my experience, chronically ill units can sometimes get forgotten about because we are, again, stuck on that hamster wheel. You have all of these higher acuity patients or higher acuity needs or higher demands that can be very distracting. Think of it as a ton of pop-ups on your computer screen. They're just kind of flashing in your face. And the real important task hiding behind all of that can get lost very quickly. So if I have all of the offenders in a specific dorm or housing unit that provides those advanced level of care, I need to make sure I spend some time and energy focusing on them, not just grinding away at what's right in front of me, trying to make sure I accomplish basic compliance with those mandate points and make sure I get the job done. but also looking at that short-term relief. And this considers their routine care. This group's routine care becomes very, very important in this process. Their routine follow-ups become extremely important to maintain. Because if I miss, a patient that has, hypertension or heart disease, or if they're an insulin-dependent diabetic, if I take some of those potential complicated medical illnesses, and I start missing some basic preventative care measures, and I don't get them seen, they're not seen with any type of regularity, I can run into a lot of very, very costly problems. So it's really important to maintain those follow-ups, maintain that connection to them for a cost-effective and efficient model. Because if I fail to provide that preventative medical care, or even your routine behavioral health care for that matter, this can really cripple my system, and it sets us further back in that consent decree, because the consent decree ties to these things most typically. It outlines the frequency in which these patients should be seen regularly, where we should be providing regular office visits. And if I miss those, I don't just fall short in the compliance, but I have unnecessary hospital visits. I may have exorbitant medical bills. I may have additional burdens placed in the agency. I may have an offender in unfortunate circumstances that successfully commits suicide as a result of failing to meet those needs at a chronic and stable level. And that not only, again, sets me back from a consent or management or mandate perspective, but also can set me back significantly financially and add to my litigation and legal issues as well. And so what's really important is to make sure that I don't just, know a couple hotspots, but I'm able to sit down and specifically review my entire agency or my entire system and dig through and identify where they are, where they exist for me. So let's say we identify a hotspot. We'll go back to the intake, for example, what we were talking about a minute ago. And we know that intakes are a major piece to any type of system we're dealing with in corrections. So intakes is my first hotspot. So how do I handle it? What do I do to manage it? This is where I have to start looking at, a couple of different strategies. I need to look at that short-term relief like we talked about before. That may mean I have to hire those couple extra people I was talking about a minute ago that help manage that influx. And if I know that, that 4 to 6 months of the year, I'm going to see that continual increase, and maybe even up to 2-3 times the amount of normal inmates come to my facility, I'm going to need that extra person or two to manage it. There's just no way around that. And so short-term strategy may be that I need to create that additional part-time or seasonal positions to address that issue or that flow. But that's not going to be the only thing I have to do to fix it. I have to start looking at not just the short-term fixes, but what are the middle and long-term fixes for the problems I'm facing. And that may mean that I need more staff as a whole year-round, because I'm burning out my consistent resources that I have from the beginning of the year. So by the time I hit that holiday season where I have that massive influx, everything I normally have is quit or gone or burned out, and we don't have the capacity or bandwidth to manage it. But maybe I need more overall, because it's not just that seeing this increase is a seasonal issue anymore. Maybe I'm seeing this increase over the course of the whole year. And I have to start looking at that information and thinking through this hotspot and say, intakes used to be 100 a week. Now I'm seeing 300 a week, and it's consistently staying up there. So now I really have to hone in on not just that staffing piece for short term, but also looking at the middle and long term processes to see how I can streamline intakes as a whole. So if I can't hire more people, what else can I do to impact that workflow? What else can I do that would resolve that problem, that would make sure I'm meeting that court mandate of 30 days or less from booking to classification? In our scenario before, it's removing that duplication and triplication of work. And that's where the EMRs and analytics tools really shine, because I'm able to start seeing those differences in time to point A to point B. I can start looking at point of care, point of value timeframes, and as a longer term process, I can say, well, I'm not just eliminating the paper flow, but maybe I retool the entire intake process as a whole. I can really key on those core components. Let's say the medical components, for example. Can I have my nurse and my provider see that offender for clearance on the same day? Can I have that intake for the nurse and provider done on the same day to simplify things? Can I have their labs drawn before they even see the nurse that morning, so that by the time they hit the provider's door, those lab results are back and reviewable, and I'm able to classify them by the end of day one? Is that possible? And I mean, I know now, COVID has kind of drastically changed things for us again. Social distancing, screening, isolations, quarantines, every entity, every organization on the face of the planet is kind of having to deal with the waves and impacts of COVID as a whole. But we still have to look at our processes, especially when under these court mandates, and find a way to accomplish them, have that data to show that compliance, but also use the analytics in the system here to help prevent return to those issues, and show that instead we're accomplishing things the way we want to, the way we need to. And where I can start, getting to a point where I can say, hey, day 1 is medical, day 2 is mental health, day 3 is education, programs, support services, those kind of things. And so I can start looking at not just the short-term relief of, yeah, we'll hire 1 or 2 more people, but the longer-term relief of, I can make impactful information-based decisions on how my overall intake process works, so that I can make those decisions and not just do that, but also have an overall positive outcome on my agency and organization as a whole.
And Daniel, just real quickly, have you found particular mitigation strategies that have worked best for you?
I've really found a lot of value in digging on a process evaluation. I found it helpful, if I haven't worked somewhere before, if it's not a personally owned workflow, that's really effective to lay out a process map, kind of saying step 1 to step 10, what are the critical steps I have to take to get there? And so, looking at intakes, if I know they show up, at bookend time, they have to be physically cleared to go to another facility, what are the steps I have to take to make that occur? And really drawing out that process map and identifying the impact to flow and pressure on that system. And once I have that all laid out, then I can create some trackable models and start putting together that framework of timelines between checkpoints, like as I was mentioning a second ago. So if I have 30 days to do this, I need to accomplish these 10 things by day 30. Let's start working backwards from there. So what needs to happen to make sure I do that smoothly? So by day 3, I know that I need to be at point A. And by day 5, point B, by day 10, point C, and so forth. So with that framework in place, now I can start using analytics to monitor my compliance with that pace. I can identify those areas where I'm deficient or slower than I need to be. And what I've seen, in our systems here, we've been able to highlight some areas where we're really excelling and start recognizing those individuals involved in the process and show the court or mediators, hey, we're making progress towards the objectives. We're not there yet, but here's the data to validate what we're doing. Here's the trends that show we're making improvements, and they're not just short-term, but they're having long-term and lasting effects. So I can see that overall time lapse between step 1 and 10 is decreasing. And I'd like to eventually work that to a point where we're consistently 90% below that mandated threshold. It gives me some breathing room on the threshold itself. If something were to occur, if we need to make a change, I have that reactionary gap to buffer things. And that goes with that workflow analysis. So if I can review everything that I'm doing, as an example before, if I'm filling out that paperwork, I'm not necessarily wasting time by doing that, but I am eating up a lot more time than I would if I did things a different way. And I won't identify that until I do that root cause analysis and dig on the analytics behind it all. So if I'm spending 30 minutes collecting information and filling out that form, then I have to spend another 30 minutes later in my day to type it into the EMR. What if I spent the time now just to type it in as I'm gathering at point of contact, point of interview, or point of treatment? And maybe it takes me a little longer to type it in than I do if I just handwrite it. Maybe I write faster than I can navigate a computer system. That's certainly possible. But if I do it, in 40, 45 minutes, I'm still saving that 10 to 15 to 20 minutes per offender that I'm interacting with, which gains that efficiency on a compounding factor. And so now I can see, as I go through this workflow analysis and identify those bottlenecks, I can gain a lot more efficiency than just making one change. And beyond that, what I found very helpful is automating things. So if I'm able to automate reports, if I'm able to automate lists that drive those day-to-day processes, they can help give me a progress map to review so I can see that, make sure things are moving well. So I can start looking at, the workflow as a whole, find ways that automation can simplify it or streamline things. Whether that's, a list of who needs to be seen in a clinic tomorrow, or a list of guys that need to be seen based on their diagnosis or issue, or when their last office visit was, or labs that they need, those kind of things. So that I can make sure nobody falls through the gaps, and that I can just demonstrate compliance and show success at achieving those court mandate objectives. And so in talking through everything we've covered so far, really the end result is being able to make information-based decisions. That's what we're really trying to drive here. Not just, data-driven items, but impactful information-tied changes And really what that boils down to is information-based resource allocation. Because if I'm able to position resources effectively, then I can start not just being stuck in short-term relief mode, and I can start actually getting through the day and the week and making lasting changes that have drastic impacts on my overall system. I'm not just stuck, in a frequent hamster wheel again. I can actually demonstrate compliance as well as prevent some of those issues or crises that occurred previously that resulted in the court mandate to start with. And that's what this next area is about, looking at that enterprise or that high altitude organizational planning, and more specifically for healthcare, digging in to make sure I have that effective day-to-day management of activities going on, that I can take a clinic and address a patient population effectively, not just handle their needs and being stuck in that short-term relief mode, but effectively look at the total overall picture. I need to be able to plan my budget. I need to be able to forecast staffing needs, do some predictive analysis on that staffing, determine how it should move, what the impact of those movements are on my patient outcomes, on care service delivery, and if I have lower staffing, what does that mean for care quality? What does that mean for patient outcomes? And look at those two things and how they correlate and start tracking those results together. And even further, not just know that information, but start demonstrating the capacity and determining the capacity for my system overall, where I have baselines now and where I need to be. And once I define that actual capacity, and that's where I can go back and make this really a cyclic machine, I can repeat any step in this process to dig further and improve more and gain more efficiency. I can go find ways to enhance these baseline capacity and baseline functions. Because when I've enhanced this resource planning and really optimized it, then I can find these new opportunities, these increased efficiencies. Maybe I'm able to streamline that process like we were talking about before for intakes. Whereas, I start now and I'm struggling to get somebody in and process through in 30 days. If I remove that redundancy, add a couple extra people, and have a tracking system that's helped push the information through. Using EMR, using analytics tool, I can dashboard out those trends so I can see that continual progress in a view that maybe I get to a point where I can shave that down to a very slim 15-day efficient machine. Where when they hit the door, I know by day 15, no matter what, they're on their way out. And by doing so, I've created this massive increase in capacity. I've gained a lot of resources as well by creating those efficiencies within my operation. And so how can I take that and reinvest it elsewhere? What else could I use the time for? Maybe I create new services as a result of that workflow analysis or that root cause analysis. I said, hey, I don't have enough management staff and medical staff to handle this load of patients or the load of offenders. Maybe I need more custody staff because I'm seeing that influx during a certain time of year. I'm not able to effectively function without these resources, and we may get through without all of these tools, yes, but at what cost? What comes out on the other side? Is that byproduct something you want to stamp your name on? And so by using the EMR, by using analytic services, I'm able to not just resolve problems and make progress forward, but I'm also potentially able to add new services to improve patient outcomes, to reduce financial burdens. And that's where this really comes full circle, not just knowing information or knowing or data exists. I can start using that information to put together the staffing schedules and cycles, to develop effective budgets and financial plans, to start tracking that information critical to my operations. Because doing so, I start seeing that I only have these finite amount of resources to accomplish our goals. What is it going to take to achieve that? How do I best do it? Again, is it really worth hiring those one or two people at a surface level? Or if I dig in, I realize all of this efficiency I've gained by just a few simple questions and a few simple decisions. I can take that finite resource pool and accomplish so much more by knowing what all needs to happen, what all needs to go in the process, and how we're doing all those different items, and being able to, again, track those key performance indicators effectively so that I know what's coming down the pipeline before it even gets to me. Maybe I realize, well, I don't just need 1 to 2 extra classification people. Maybe I need 20 additional officers, 5 additional nurses, a new provider to handle the influx. I'm never going to gain that information just by hiring those 1 to 2 people.
So Daniel, what are some of the ways that electronic health records and analytics can support information-based resource allocation?
So EMR and analytic tools are really where you start driving that information. So without those key components in your system, you're left with that paper process like I was talking about before, where it becomes very difficult to quantify what's going on and qualify that care delivery or the outcome. And so you're stuck without tools to effectively do the job. So we can drop one of the components out of the equation. Let's say, without an analytical tool, you're left with an EMR, which is good because you're able to generate some reports. You can, of course, capture a ton of information, a ton of data. But those reports and that information, maneuverability may be limited. Or if it isn't limited, it may be extremely labor intensive when you're trying to drill down and look at some of these issues and figure out what do I need to do to get out from underneath this mandate. And that's where this whole process shines when used effectively and used concurrently. So if I have both tools working collectively, I'm able to not just gather that key information, but I can gather it, I can package it, put it in the right people's hands in the right room. I'm able to dig in, go through the cycles we've discussed before, and track that progress with a tangible pulse. I'm able to demonstrate compliance by showing those improved outcomes. And ultimately, I'm able to make informed decisions in the system with a lot of information at my fingertips. So I can figure out how to position my resources, my officers, my nurses, my medical staff, behavioral health staff, psychiatric staff, most effectively to prevent issues before they occur and also manage the issues that are occurring in real time right now. And it's typically what a mandate is looking at actually is having a system prove that they can do that, having a plan in place to mitigate those challenges when they arise and prevent that deviation from what's determined as appropriate practice or standardized procedures that ensure overall well-being.
And Daniel, can you give me a couple ways that this has impacted South Carolina specifically, this information-based resource allocation?
Sure. So unlike, not unlike anybody else, we're all kind of dealing with this universal resource shortage. Every state, every correctional entity could always use a few more nurses, a few more medical providers, a few more officers, and a few more mental health clinicians as well. I think the mantra is do more with less. One of the things we've been able to do is really identify where those critical needs are in our care delivery process. And so we've been able to add a few counselors, a few qualified mental health professionals and social workers to our system to provide that improved access to mental health care, specifically in intake, specifically in, segregated housing units, those kind of things. Also identifying offenders that need to be added to the caseload in a more efficient fashion so that I'm able to get them services quicker. I don't have them hit that crisis level event before we get services to them. I'm able to identify them at an early process and get them seen more effectively. And from a medical perspective, I'm able to see those medical conditions or medical statuses and trends, that before an EMR, before analytics tools may have gone unnoticed longer. We're able to get them reclassified faster, appropriate medical care faster as a result of that. And without those tracking systems, without the EMR, without the analytics, you're driving all of these changes and all this information from a lot of different sources, a lot of different resources, and it can become very difficult to track effectively and to manage effectively. And that's where the EMR and analytics become invaluable, is that they are able to help assist with those lifts effectively. And you're only operating with half of a picture if you're missing those components. And so without that total picture, we'd only be able to make some educated guesses or halfway decisions. And that makes things very difficult to drive forward effectively. So to kind of sum up, as a case study, kind of what we've dug through today, we've put together a case that we found recently in a system where we had 300 diabetic guys that hadn't had an A1C in the last 5 years, in facility X. So going back to our model here, we want to kind of walk through this collectively and figure out what happened and why. So why did this happen? I have medical staff, I have nurses, I have doctors, I have officers, I have everything in place. But then when I start digging into it, I look at the layers and I start asking myself, why did this happen? What happened? Why? I can start seeing, well, I only have 5 doctors and I have 15 facilities. So they're each covering 3 facilities. Well, okay, that doesn't sound too bad, but each facility's population can range from, 500 offenders to maybe over 2,000, 3,000 offenders. And that can create a very sizable issue if you only have one physician to handle that kind of a caseload. So I'd see that, all right, that may be an issue, but is that really my core issue? Why is my population, struggling with this? What's going on? Who in my population might be affected by this? So I need to dig further. I found, there's 300 inmates here, but is there additional group that I haven't found yet that needs to be included in my cohort. And so, of course, I need to immediately address this issue and say, well, we need to get these guys seen. We need to get that A1C drawn, and we need to make sure that we put a schedule in place to make sure this doesn't repeat itself. Because that A1C is a critical component to managing their diabetic care. It helps me understand from a medical perspective, are they appropriately medicated? Are they appropriately maintaining their diet? It's a really great tracking mechanism for diabetic regimens. But I need to figure out where that breakdown occurred and why. It may not be that I didn't have just enough physicians. Why didn't alarm bells ring before now? It's been 5 years for some of these guys that haven't had an A1C. And if I don't have that A1C consistently, what could happen? That could mean I have an uncontrolled diabetic who has severe complications. Maybe we have, a diabetic foot wound that results in an amputation, or maybe they have kidney issues or eyesight loss or blood pressure issues, because all this stuff ties together. And so I really need to get a handle on what's going on and what happened. So I want a dashboard and track all of these patients needing that A1C. So this is where my EMR comes into play. I'm able to see, all right, these are all my A1C values for all of my diabetic patients. I can see when their last A1C was. I can see what, using an analytical tool, I can see the last few. I can see what the next one should be projected to be drawn. And I can make sure at a minimum, we get that done. But going beyond that, I need to figure out how do I improve the process as a whole. If I don't change the staffing, if I don't change the population, this is likely to repeat itself. This could happen again, even with the best tracking system in the world. So I see I only have 5 docs. Well, that means I need a few extra physicians. And we may need to not just add physicians, but maybe I need to add nurses. And so I can start setting up, weekly meetings with HR to look at their processes, to start hiring initiatives, to look and see, well, what else can we do to bring in these care resources. And then from there, I can look at, the medical process as a whole with monthly provider meetings to make sure there aren't any care gaps or adverse reactions to that deficiency, and then transition that to an annual review, to make sure I have, 100% or 90% or what am I set my target as to be annually reviewed like they're supposed to make sure we're trending that trending over time to hit that mark and demonstrate that compliance. If you bring this out full scale and realize, well, okay, so my population has 10% of it that is an insulin-dependent diabetic, but my state's population is sitting more in that 30% ballpark. So what tends to happen in those situations is that the population will balance out. So that means I don't need to just plan for now, but I need to start looking ahead to their future. And this is where that analytics tool becomes invaluable. I can start seeing, okay, what's going to be required resource-wise to handle this care load? Because as that population averages out, I need to understand what does it look like for my system to handle that 15% mark, 20% mark, 25% mark, because it's safe to assume that population is going to average out. And I need to be mindful of all of this and ensure that if and when that population shifts, I'm not just reactionary. I don't get stuck in another court mandate situation, but I'm able to plan, and not just plan, but develop effective solutions within my system because of the EMR and the analytics I'm deriving this information from, and I'm able to address them now before they become a crisis. Or if they are a crisis, I'm able to manage the outcome more effectively and demonstrate compliance with qualified data and patient outcomes.
Thanks, Daniel, for running through that example. Before we wrap up and head into questions, I wanted to give briefly maybe an example from a different vantage point. We worked with a medium-sized county in Maryland to apply these same types of principles, analytics, and basically enterprise resource planning. There, the goal was to lower the recidivism rate. It was a very, very successful endeavor. In fact, at the end of this presentation, we'll give you a link to a white paper. It's also available in the handout section of the GoToWebinar toolbar that you probably have on your screen. There's a handout listed. You can download that handout, and the link will take you to a website where you can pull down the white paper that talks about what was done and the impact that it had on recidivism and some other key factors in that county. So it's not just clinical areas where analytics can help. So with that, I think we'll move on to questions, and Christina, we'll turn it back over to you.
Oh, awesome. Thank you so much. Guys, this was just terrific. Thank you so much for that presentation. And folks, if you're like me and you liked this webinar, then be sure to check out our whole lineup of webinars on our law enforcement feature page, where you'll find another related webinar. Join us on October 26th when the great folks from the NCCHC are back to talk about how health services and custody can work better together and foster better working relationships. So if that webinar is of interest to you or your agency, all you need to do is go to the justiceclearinghouse.com website, go to the navigation button called webinars, and then drop down to law enforcement. So do take some time, check those out. We'd love to have you join us. Folks, we are running just a hair over in terms of time today, so we'll just take a few questions. So Gary, Daniel, are you ready?
Yes, ma'am.
Awesome, perfect. Okay, so Daniel, you talked about identifying changes within a system. So, for example, eliminating the duplication or triplication of efforts. How do you get buy-in from the employees who may not necessarily like the changes you're making, or help them to understand why the changes are being made, and especially to help get those changes done for the long term? Can you talk a little bit about that?
Absolutely. So buy-in is really critical in this process, because without frontline staff buying into the changes or into the adjustments we're making, the system won't have the information, the analytics tools won't have the information you need to be able to effectively make those decisions we're talking about. So what I found is very useful is to make sure that everyone understands the overall goal, everyone understands the reason behind the change. And if people can understand the reason behind it, the why, then they're more often found to agree with that, or to say, well, I can at least understand why we're trying to do this. This may not be the most pleasant experience, but I understand the why. I understand the need for it. So if we're able to address that why question, I've found that buy-in significantly increases. And not just that we want to show them why they have to do it, but show them the impact that this could have. If, going back to the original example, you say we gain a lot more efficiency by doing things this way, and after that initial unpleasant week or so of learning how to navigate the system, you realize, hey, I actually get twice as much done in my day, whereas before I was frustrated, I was only seeing 5 guys in my clinic. Well, then they start seeing the why for themselves in real time.
Oh, nice. Fantastic. Thank you. Next question again, Daniel. You talked a lot about systems and processes, just like you just did just a few seconds ago. What's the role of training and policy development in this work, especially like when you're trying to identify hotspots or ensuring the consent decrees are met?
Training is a very, very critical part to the process as a whole. And so as I do these root cause analyses, as I identify that core problem, oftentimes it's because we didn't set up a great training program to start with, or because our training program hasn't sufficiently met the needs of the organization it's responsible for. So if I have half my staff trained, I'm most definitely going to run into systems issues or policy deviations where we don't hit the mark that can result in these court managed lawsuits. And the same thing if I don't have policies and procedures that are well outlined and easy to follow, and that we work through on an annual or semi-annual basis to make sure all staff understand, hey, here's what we need to do effectively to accomplish the job safely and adequately. Then they can make their own decisions sometimes, and that may deviate from what we're supposed to do or how we need to do things, that can result either in harm to them, harm to the offenders, or an unfortunate event that results in litigation as well. So training and policy development are very integral into this entire process, yes.
Fantastic. Folks, we have time for just a couple more questions today. Next question, Daniel, do you have a sense as to the percentage of correctional institutions who are embracing telehealth like you were talking about a little bit ago in your presentation?
I don't have an exact percentage. I do know that it has significantly increased as a result of COVID. I can say from my personal perspective, the demand for augmented virtual care delivery systems is very, very large. And it's not just in the correctional environment, but also in the entire health environment as well, World Health Organizations as well, looking at expanding services. What we see is there's a lot of resource demand and not a lot of resources to meet that need. And the only way we can effectively do that is by utilizing these services. Correctional entities often, or the most resource depraved, if I can use that phrase, just because they're often not thought of in the same sense as a hospital or an outside ambulatory clinic would be. And so telehealth becomes a vital resource for them to tap into. And I think that trend is continuing to expand as we go on through this process as well.
And Christine, if I could touch on that too.
Of course, please.
Yeah, about half the states that we're aware of have embraced telehealth in one form or another. Many of them, by the way, before COVID was an issue. I think what COVID has taught them, though, is a lot of them embrace telehealth in the form of like Zoom or WebEx, inexpensive or even free products. What they've learned is they need products that are integrated with their electronic health record, because just having the ability to see someone in a video isn't the same as being able to really perform a true telehealth encounter. So I think a lot of them are not only are starting to embrace telehealth, but those that were early adopters are starting to refine their expectations of telehealth.
Fantastic point. Thank you so much. And last question of the day, folks. Daniel, have you been able to quantify how much money these tools and these processes have been able to save?
A specific amount, no, but what I can say is that we have significantly improved our care delivery and our care outcomes as an entity. And so what we're seeing now is that we're able to better serve our population. We're able to see a reduced return of offenders back into our systems for medical purposes, which reduces the financial burden placed on the state and placed on the taxpayers at the end of the day, or the organization that's managing it, if it's a private entity, that allows you to reinvest those resources elsewhere. And so it's going to be dependent upon the scale of the system implementation it's put into. But there is a definite return on investment and a realizable gain here with this model.
Fantastic. Well, I couldn't pick a better place to end today's webinar. Thank you again, both of you, for doing such a fantastic presentation today. And folks, be sure to join us right back here tomorrow when we'll be talking about what your agencies need to know about the launch of 988. So do be sure to join us, or have somebody from your organization or agency join us if you can. And with that, this concludes today's Justice Clearinghouse webinar. Have a super rest of your day, everybody, and we'll see you right back here tomorrow. Bye now.